one of our TME roundup series from the Pelican Cancer Foundation in Basingstoke, and as a grandfather figure, I feel huge pride here because there's Brendan Moran, who is the
grandfather himself,
current boss, and here Mark Gudgeon, another of my past registrars from God knows how many years ago, who has really been the first person in, well, this part of England certainly, and one of the very first people in England to do robotic live surgery on the humans. And as I remember going and watching Mark with his early cases at Frimley Park Hospital, and since then he'll talk us right the way through the progression of technology as applied to one of the most important operations in cancer, which is TME, total mesorectal excision. But how proud I feel the former registrar's gone on to great glory. It's huge fun to have you here, Mark, and well, Brendan and I are side by side in Basingstoke, with me being a bit of a nuisance and him being the boss.
I think there's very few people who have actually taken on TME from open surgery, laparoscopic and robotic to the level you have, Mark. I think it's a rather unique. Can you tell us, first of all, your experience with open TME with Bill?
Well, my open experience with TME with Bill was back in 1985, Bill. That's how long ago it was. And
85, that is nearly 40 years ago, Mark.
Yeah, and I was very much encouraged by one of my colleagues and another former registrar of yours, Simon Huddy, who an excellent surgeon, very good at TME, and he advised me to go and work with you, and told me then that he said you won't ever see a TME like the one done by Bill. And I would watch various surgeons up to that point, and he was absolutely spot on. One couldn't say it at that stage in my career because that would have been suicide, but it was a different experience seeing the TME with you, and that from that point on you switched my desire from orthopedic surgery to general surgery, and I became enthused with the TME and learned a huge amount working with you. I never did the complete operation while I was working with you, but I did all the various bits, and when I went elsewhere I was able to put those bits together and build on that, even though some of my bosses weren't doing it necessarily in that way. So that was a huge privilege to get on that, and then it's a long learning curve. It takes a long time to build up that experience with TME, and it went on open TME into my consultant career, and then laparoscopy came along, but that's probably for a little bit further down the line.
But I think it's important to because you I think always felt that laparoscopy was instruments, it was technology, but it just really was still the same operative procedure. I think it was.
I think that's true, and obviously, like everybody else, I fairly late on in my registrar career. I think my first laparoscopic cholecystectomy was done as a registrar before going on to being a senior registrar, and that would be back in 1991. I came back from a year in Australia. In Australia they did their first laparoscopic cholecystectomy in my last week there, and they blacked out all the windows and they wouldn't let anybody go in to see and they came out 7 hours later with a tiny little gallbladder, and I thought my word, I'm not sure this has got anywhere to go. But as time went on and I returned, I ended up working with Mike Bailey in Guildford and started to learn laparoscopic cholecystectomy there, as well as with Jay Simpson in Chichester. And I think I was lucky because I found it relatively straightforward, and I seemed to be okay at laparoscopic surgery, so I was keen to develop it. And even at that time, back in Chichester as a registrar, I was trying to persuade Jay that we should be doing some colorectal cases, although nobody was really doing very much of that, but he wasn't terribly keen to move on to that. But I'd kept that into my back of my mind. And then as things developed, I kept doing laparoscopic cholecystectomy, even though I was a colorectal surgeon, or a major interest in colorectal surgery, and did various other laparoscopic operations just to keep the skills going. And then as time developed, there were one or two examples of laparoscopic colorectal surgery that didn't go well. There was a particular case, I think, was demonstrated live at the London hospital, which didn't go all according to plan, and it put people off for a number of years. And then in 2003, I decided that, well, we're going to give it a go. We got some of the equipment. I went to Strasbourg and went to the course in Strasbourg, and you were there, Bill, and I watched this medial to lateral, which I'd heard about but hadn't seen, and thought that was a moment that made me decide that's what we're going to do. So I went back, and the following week I did an open case, lateral to medial, in the same way that Jean Loire had done it so beautifully, and I did
Jean Leroy,
Jean Leroy,
French, yes.
Jean Leroy, and which he did an extraordinary anterior resection, start to finish, in about 2 hours, which was just a work of art, and I was so impressed. So I went back and did the same thing with an open case, and then the following week did a laparoscopic case that went very well, and we just built it up from there. There were no preceptors at that stage. There was no one to teach us, so we were learning on our feet and flying by the seat of our pants, really. But I think the principle that we worked by was do no harm, and that if we had any doubt about the operation at all, any concerns for safety, we converted to open.
It was almost much easier to do that, wasn't it? Because nowadays, all of the younger surgeons will have been brought up with laparoscopic surgery, and there's almost a unwillingness to change the plan by making an incision. So I think that's one of the...
There's a sort of virility feel about it, isn't there?
They did, and it was brought in the early days of LAPCO. It was a measurement of success, was conversion rates, and I was always very against conversion rates, because I felt that it's much safer to convert at a safe time than to carry on because you feel you have to compete it laparoscopically and do more harm than good. So I never...
Some of the greatest or most famous surgeons in the world I've seen persist to the undoubted harm of the patient, really.
I think one of the things that you and Tom, because you then of course were involved in the LAPCO, and you introduced this term of adapting the incision, didn't you? Which is, so in other words, you made the incision as big as you needed to make it, whatever that was.
Absolutely. I think because of course I worked with Tom Cecil, who a colleague of yours at Basingstoke, and that's how we built up our experience, because he started shortly after I did, and we used to go to each other's hospitals, and we worked on the laparoscopic cases, built up our experience, and talked to each other through the operations, talked to each other on the phone afterwards if we'd been doing it on ourselves, and we built up this experience together. But we never had the issue of conversion. It was safe to convert, and the most important thing was to do the best cancer operation in our view, and if we had to convert to do that, then we didn't view that as a failure. And I was always concerned about the measurement of conversion rates as a measure of success.
The other thing I think that I've noticed, because I was there when Tom was developing it, and indeed when you were, and we used to come to our operating theatre now quite a bit. But I think one of the things that Tom, and I think he and you together developed, was the idea that it takes a long time, but that doesn't matter if you're making progress. What's really bad is if you're taking a long time, several hours, and making no progress. So if you're 2 or 3 hours in and you're making progress, then that's fine. But when you get to the stage, and that's you really need to have some measure of progress, don't you?
You need progress, yes. I think it
mostly the holy plane was where you had to be, and you had to be progressing in that plane, didn't you? And once, what I've seen again and again over my teaching career anyway, is that once people get out of the holy plane, especially laparoscopically, because you are missing some of the open information that you get from being able to look around and move the things with your hands and so on. Once you're out of the holy plane with minimally invasive surgery, you are totally lost. Is that not true?
I think that's
Nearly
true.
true
I
anyway.
think that is true. But in many ways, I think I've found with practice it's easier to keep in the holy plane laparoscopically than it is open, and I think one gets very used to the visual clues rather than the proprioception. Our hands are a very useful tool in surgery, and one has to get used to not having that proprioception, which does make a big difference. But I think once you're in the plane, and if you can keep in the plane, it's excellent. If you get lost and you get outside it, which you've probably seen in your various travels on occasions, you can get into serious trouble. Get lost. If you get bleeding, you're completely sunk in laparoscopic surgery. It's very difficult. You lose the light, you lose the vision, and effectively it can be a disaster.
You lose control.
You lose
too.
control.
You can't
Yeah.
exactly put your thumb on it, can you?
What are the big advantages, Mark, with laparoscopic? And then we'll move on to robotic. But when you clearly refined laparoscopic colorectal and indeed laparoscopic TME, and you became incredibly adept and very good at it. And what are the big advantages? You think it's the vision, the instruments? What is it?
I think first and foremost it's the vision. One gets you get a magnified view, probably a little bit like if you were doing an open operation wearing loupes. You get the magnified view because it brings everything in more closely. You've got the precise dissection. One can see what one's doing, but there are the instruments. They have a fulcrum at the point of insertion at the site of the ports, and that limits the amount of the angles of freedom that you've got compared with open surgery. So you are more limited in terms of the instruments and the way that you can move, but you learn to adapt to that. With the laparoscopic, you're very dependent upon a good camera person, because particularly when one's working in a tight place within the pelvis, the camera can catch a bit of fat and smudge, and then you have to take it out and clean it, and constantly doing that can be quite frustrating. It can be quite time consuming. But these operations, they do take longer laparoscopically, and I think some of the operations, right hemicolectomy and the abdominal ones, we've got down that we can do them as quick, if not more quickly, than we could do them open. The TME is a little bit different. One has to take a little bit more time, a little bit more care in order not to get bleeding or get into the wrong plane. But that doesn't seem to have a negative impact on the patient, providing you, as you say, you're making progress and you're not causing complications. Then we do see a faster recovery. The downside in terms of laparoscopic TME is once you put an ileostomy in, that's the thing that has the major effect on recovery, whether it's high output ileostomies, obstruction at the ileostomy site. Those are the sort of things that seem to slow things down in terms of the postoperative recovery. But overall,
I so want to get the leak rate down so that we don't need the loop ileostomy. I've always preferred the right transverse colostomy, as you know, but that is a different argument. And we haven't mentioned what's actually happened to the quality of the images we're looking at in minimally invasive surgery. They've gone from what were really quite pedestrian, unacceptable imaging for really doing precise surgery at the beginning to 4K, and well, the 1080p and so on is pretty good. But you get to 4K and better even, and that's made a real difference because you actually can see the shine, you can see the tiny vessels with the magnification and so on. So, I mean, it is really advances in video imaging that have led the way for surgery.
Well, I think yes, the advances in technology and and that's on the back of the entertainment industry rather than specific surgery, isn't it? The quality of images has come. I can remember in our very early laparoscopic days, and you came to our theatre in those days, is we had the horrible little screen that you could barely see anything, and I bought a large TV and connected it with a cable that I'd bought in Curry's and plugged it in, and we got a much better image on the screen. And Chris Eden, who was doing the prostates, he bought a projector and had a massive projector, which things. But now that has been all transformed by the industry, and we've got superb images.
With
now.
my open TME teaching, which I did around the world, more than 60 countries, Mark Coleman worked out. I'd been with my, I went through a long progression through the various cameras. The mini DV phase, when 1080p arrived, was a big step forward for teaching, because you could get a camera mounted on the light, and you could, if you took a lot of trouble, didn't get your head in the way and so on. But then the huge advance once you got to laparoscopy was that you actually had to have the image, and you can then teach. Other people can watch.
Can we just go back a little bit there, Mark? One of the aspects that I noticed, and I still notice a bit, is that we, doing TME, if you're going to do a low anastomosis, in my mind, you almost always need to bring down the splenic flexure, which has a risk at open surgery. And Bill and I famously have well, I think I did it actually, in 2 live cases, we had to take the spleen out for splenic injury. The patients didn't come to any great harm. But it seemed to me as if when people started doing laparoscopic TME, they thought that actually they didn't have to take down the splenic flexure, even though technically taking down the splenic flexure can be nicely done laparoscopically.
Do you more safely too.
Yeah. Do you sort of think about that as a routine part of a low anterior resection, either laparoscopically or robotically? Just getting back to the fundamental aspects of TME.
I, at a very early stage through doing the laparoscopic TMEs, I changed from doing the TME first to taking down the splenic flexure first. And the purpose of that was we'd had 1 or 2 early cases where we'd done quite a nice TME, and then we needed to get the splenic flexure down. And it was just impossible for my skills at that time, and and then we had to make an incision to bring down the splenic flexure, and it's a difficult and time-consuming part of the operation in certain cases. Sometimes it's very easy, but often it can be difficult and time-consuming. And I feel that if you get it out of the way first, then it makes the decision making much easier. You say, I'm going to take the splenic flexure down. If you don't need to do it, well, fine, you haven't lost anything. But at the end of a difficult TME, it can be quite challenging to have to suddenly switch on, right, I've got to do a difficult splenic flexure, and doing it the other way around, I find, is much easier. There's occasions where you'll see somebody with a very long sigmoid colon, you've got plenty of length,
especially in Africa.
Well, I haven't done many cases in Africa yet, but yes, the long
there is
sigmoid.
An ethnic difference,
yes.
I think. The very long splenic flexure. Sorry, a very long sigmoid is very common in Africans.
And we do see some, but and in that situation, I probably wouldn't take it down. But in most situations, I'll take it down as the first part of the operation.
Yeah, and I think that's so. Probably you need to plan, and that's one of the things at LAPCO and now in the program that Tom and you are going to do this afternoon, the training the trainers, is that you need to plan what you're going to do beforehand. So, for instance, it's interesting. I never stopped doing mechanical bowel preparation for rectal cancer, but actually it went out of fashion, and people said you didn't need to do it. It's now in fashion again. Do you do mechanical bowel prep?
I've always done mechanical bowel preparation if it's a low resection and we're going to defunction. So I don't
all rectums.
All rectums, because I don't like the idea of leaving fecal material close to the join, even though it's defunctioned. So I do bowel prep those.
There were papers saying it was safer not to do it, but at the same time, I was hearing from the Bush Telegraph absolute catastrophes occurring that weren't in the trials.
Yeah.
And it was a very bad idea, I think, not to prepare for the very low, not to have an empty bowel for a very low anastomosis.
And I think if it does leak and you've got a full bowel, then you're going to get sepsis, you're going to have to go back and reoperate. If they've got an empty bowel, you'll often get away without having to do anything further other than...
So it's those are the sort of planning aspects. Mechanical bowel preparation, probably have to take down the splenic flexure in most cases, and be prepared if you're going to do a minimal access technique, that there is a risk you may have to enlarge an incision, what you and Tom called adapting the incision to the requirements of what you have to achieve. I think it's a good term. Instead of, there's almost a sort of a negativity about conversion, Mark, isn't there? There's a negative, but actually, if you change the terminology a bit and say
surgical common sense
and adapting for what you, so I think that's important. So the laparoscopic. So you, for many years, you were very comfortable and very happy with laparoscopic TME, and I think you did a lot of laparoscopic TMEs, and open surgery was still practiced in your practice. I think you never felt that you could abandon open surgery completely. So what proportion did you get to roughly when you were doing laparoscopic TME of all your rectal cancers? Roughly what proportion? 60, 70%, 80%?
Probably 80, 90% we were able to do laparoscopically with a conversion rate. And the difficulty also, just going back to the conversion, is one, we struggled in LAPCO to come up with a definition everybody could agree for a conversion, and everybody has a slightly different view of what a conversion is. And we were quite strict about it. Anything where we had to enlarge the incision, either to do the stapling or any other part of it, that was a conversion. So our conversion rates came up as relatively high, but most of those were for the stapling, because the stapling in the low rectum is a crucial part of the operation, and sometimes the laparoscopic staplers just weren't up to the job. You couldn't get into that tight space, and we had to use one of the open staplers to get a better stapling. So that's the conversion, taking the conversion into account.
Shouldn't we stop on the stapling, because I've got involved with Antonino Spinelli, who is a very nice and competent Italian surgeon in Milan, who is very keen to get a big trial of what he calls TTSS, which is saying that the transanal thing, the only really valuable part of the transanal thing is the transection of the bowel in exactly the right way, eliminating all the obliquity and multiple bites that is often necessary from above. And in Basingstoke, and obviously you from Basingstoke are saying sometimes you have to make a bigger incision in order to do a low stapled anastomosis, and I think probably you do. And Basingstoke, they're still doing the same thing that Brendan and I have done all our lives for a low anastomosis, which is taking advantage of the upward pull on the first stapler, washing out below it and putting a transverse TA45 across. And that you can do through a suprapubic. Are you on to that ever?
On occasions, but slightly differently, because we use the technique of taking the dissection right down to where it cones at the pelvic floor, and then I put a nylon tape around the rectum below the tumour, tight with a modified Roder knot. And then we do a washout. We've always done a washout because I believe there are occasions when implantation can occur. So we've always done a washout, but that's something I learnt with you, and I've always kept that up. And then often with that nylon tape, you can grasp the nylon tape and you can manipulate the rectum without tearing the mesorectum. You can do much more manipulation than you can if you haven't got the nylon tape on, and you can often get it in to the laparoscopic gun, where you wouldn't have done otherwise, with just one, maximum 2 firings. We very rarely had more than 2 firings. We'd often do it in 1 firing by using that technique. If in the event of it being an incredibly difficult one, we tended to use the Ethicon gun that staples both sides and then cuts down the middle, rather than using the two staplers, because we'd already washed out below the nylon tape. But now there's been developments, we've come on to the robots and robotic staplers and so forth, that may make that better. But I think the stapling is absolutely crucial. I've never been a fan of multiple firings, and I think all ours have been 1 or maybe 2 firings at the most.
Do you have any thoughts on TTSS? Not yet.
Well, my concern.
Can you tell us what TT? You need to define it. What's the stand for? TTSS.
It stands for transanal transection and single stapling.
Yeah, TTSS.
And the idea is that you do all the dissection from and above. I got involved in this because in my sort of semi-retirement, I've seen a lot of transanal TMEs and come to the conclusion that actually most of the dissection is easier from above than it is from below. You're
and safer,
nodding and safer.
The world has come around thinking
long learning curve for TME. Well, Antonino has arrived at the same place on that, having done several years of TME, and he's now keen to get people to think about taking what he thinks is the best bit of TME, which is the transanal transection. And I know your very first one, you had a leaking purse string, and you got a local recurrence, didn't you?
Doing a TAR TME, yes.
Yeah. But anyway, he's just saying the best bit of TME is transanal transection, and then single stapling, simple old-fashioned single stapling, but doing the purse string, distal purse string from below at the end, having done the dissection at the beginning. So it's changed the order of TME and taking just part of TME as an alternative. But then another alternative is to have a suprapubic incision and do Bill and Brendan's...
But I think that the robotic thing and technology again, so I think we probably need to have a little break and come on to the robotic in a moment. But I think what's clear is that, to my mind, and what we need to get across is that the fundamental aspects of TME are the same. We need to define the steps. We've gone on to stapling, but actually we need to define this, and the planning starts at, when you examine the patient, where the cancer is, MRI scanning, and then planning the operation, which requires a bit of thought as to whether you're going to take down the splenic flexure, which to my mind is almost always, you may occasionally get away with it, but actually you need to think it through, that it probably needs to be done for a low join.
Yes.
And then you have better vision, better instruments laparoscopically, but it doesn't solve all the problems. And I think we probably should come back to some of those things when we discuss the robotic aspect of why robotic is better. But I think we're all agreed, Bill, and I even wrote a paper many years ago which said that laparoscopic, even though it's arguing for open surgery, that laparoscopic might there be better vision and might be better for teaching and training, which I think has been shown to be true.
Well, there aren't many nuts anyway that'll go around suspending cameras on and almost none of the cameras in theatre operating room lights really give you a very good picture for the person who's watching.
No. So I think we should probably have a short break and come back to the robotic element. You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. And thank you very much for joining us.